Our next presenter, Dr. Akito Hirakata, who's here from Japan. Thank you for making the trip.
Thank you. I will present the macular hole retinal detachment in high myopic eye. This lady has a decrease of vision, and she has a previously cataract operation and anti-VEGF treatment for the CNV, and she recently decreased vision very well. And the next slide. So this is a total retinal detachment with macular hole, and we remove the gel as possible, and I inject the triamcinolone to observe the posterior hyaloid. But retina is very movable because of the total retinal detachment. I inject the powerful carbon liquid to stain the posterior pole, and also I inject the BBG staining to make sure the ILM or not. And I remove the posterior hyaloid. Posterior hyaloid usually attached very tightly, and I remove the posterior hyaloid with ILM, and also I make plan to do the ILM flap technique to macular hole. Sometimes very adherent, and it is impossible to separate the posterior hyaloid ILM very clearly. And also the BBG can be very helpful to see the ILM. I am not sure how much the powerful carbon liquid should be injected, but this time I inject like this. And also the posterior hyaloid. This is the ILM flap. I insert the flap to the macular hole, and also I remove the posterior hyaloid as much as possible to the peripheral. Sometimes I use a bimanual technique to using the light pipe. But this case, during the peeling of the posterior hyaloid, I make the break. So I remove the subretinal fluid, and I did the fluid air exchange. And I use the tamponade, SF6 tamponades. I put the laser to the peripheral break. And also the sutures for the most of the cases of the macular hole retinal detachment because of the high myopics to stable the IOP. So after that, could you go ahead? The retina attached, and scar of the CNV was present, but the condition is okay.
So there was a retinal detachment present at the beginning of the case?
Beginning, yes.
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 And so with out of break, would you have drained through the hole?
I drained through the hole, but during the removal of the posterior hyaloid, also retina is lift up. So I inject the powerful carbon. Yeah.
Dr. Yonakawa, what is your preferred stain for ILM?
ILM BBG now.
You use BBG?
Yeah, also in Japan, most of the surgeons prefer the BBG. ILM, ICZ may be okay, but safety concentration is not stable, so we prefer the BBG so far.
I wish we could use BBG too. I think that would be preferred, but in the US we only have ICG available usually. Otherwise you have to have it compounded, and there are compounding issues. So we have to use ICG for the majority of us. And when we have macular hole detachments, I like to put in PFO first, and I create like a bubble of PFO over the macular hole, and then I inject ICG, and so that the ICG doesn't go subretinal. And I kind of move that bubble around to stain it while still plugging the hole. But with beryllium blue, it stains beautifully. I would love to use it.
We're going to continue with these cases here.
Also, in high myopic eyes, without macular hole, also the foveal schisis was present. That is maybe a precursor of the macular hole retinal detachment. This case is a metamorphopsia, and vision decrease, and refraction is minus 18. And I remove the posterior hyaloid. Also use triamcinolone staining. And also the posterior hyaloid membrane attached very tightly, and Sometimes the removal of the posterior hyaloid is very sensitive to prevent damage to the retina. Also, I use BBG staining in this case to removal. This is a very fine staining, but maybe during the removal, you can see the iron removal. Actually, to prevent macular hole opening after operation, I try to do the fovea sparing IRM technique, but during the removal, naturally the IRM lift up. Sometimes it's occur. And I did the air tamponade after that. Could you go ahead, the next slide? And also, after the operation, the fovea schisis is getting reduced, but 1 month after surgery, macular hole open. That is sometimes occur in this operation. And I injected gas tamponade, next slide, and macular hole closed. So in this case, maybe the vitrectomy is okay, but to prevent the macular hole is a little bit problem. So recently, I tried to do the IRM sparing of the fovea areas. But we are not sure that is okay or not.
So did you go back to the operating room, or you injected a bubble in the office?
In the office.
What gas?
SF6, pure SF6.
And how much?
Over 5 cc. 0.5 cc. I'm sorry, 0.5 cc.
And then just face down?
Yes, at the outpatient clinic.
For how long?
And maybe 3 or 4 days, and I checked, and already the macular hole getting close.
And so you, on your initial surgery, filled with air?
Yes, because I thought that this macular hole is not completely, so I did air.
Air, and no position?
No positions. And this is a very similar case. Recently, the glaucoma combined schisis, just like the optic pit maculopathy. And this is a glaucoma eye, and left eye has a macular schisis. Could you go ahead? And schisis is like, yes, and there is no optic pit, and I just observed for 6 months, but the foveal detachment developed, so we did a vitrectomy. And already PVD present, but thin hyaloid membrane attached at the posterior, so I remove the posterior hyaloid with IRM, just like the HIMAP using the triamcinolone and the BBG staining, and remove the also IRM. Also, I try to do the IRM sparing at the fovea, but also the lift up. Maybe my plan is very small for the sparing, so maybe the larger is better. So I did the air tamponade. Could you go ahead? And after that, also the macular hole developed 2 months after surgery. That is a problem, and I inject also the. At that time, I did total fluid air exchange, and SF6 tamponade was performed, and after 1 month, macular hole closed.
So I'm going to ask the panel, Dr. Osdek, what gas do you prefer after your macular hole?
I personally use SF6 gas, 20% SF6 gas, and in such cases, actually, it happens in optic pit-related macular detachments also, and it looks very like optic pit-related maculopathy. And when you do the ILM peeling over the macular area, then you may unroof the fovea, and it may end up with macular hole. So I have abandoned to peel the ILM over the macula in optic pit-related macular detachments. That's because of that. And some myopic eyes also have such thin wall in the fovea. So sometimes you just leave the ILM over the foveal area, just to avoid this complication.
How large area do you?
It's difficult, I know.
One disc areas?
You're right, something like that. And I always put gas, even if I don't have any macular hole. In such case, I always put gas because if you have intraoperative OCT, for example, you may see if you have induced a macular hole or not. But even if you didn't induce a macular hole during the surgery, it may end up with macular hole after the surgery. So it's better to use gas.
And then do you position? Face down positioning?
I do. Try to do it for 4 days or something
4
like
days.
that.
And so does anyone on the panel not position their macular hole patients? No.
So I selectively do non-face down positioning for low risk holes like stage 2 or early stage 3. But yeah, that's maybe a fourth of my patients.
So if I have a flap over the macular hole, I don't position my patients. So if I'm able to put a good flap over the macular hole, then I just put air and tell them maybe
air.
the first day face down and after that.
And maybe one day face down and then done.
Yes.
Also for the gas tamponade, we observe the swept source OCT findings, and under the gas tamponade also we can observe the macular hole closure or not under the gas. So in that case, depending on the situation, we postpone the prone position or not.
And so you perform OCT at every,
Yeah, most of the cases.
through the gas?
Yeah.